All right, everybody. Welcome to DaVinci Academy's live review this morning. I guess maybe night for some of you who may be watching in other parts of the world. Appreciate you guys tuning in. This is our third live review. We do about one of these per month, so we've been doing them once for the past 3 months. And in this review, we're going to be covering cardiovascular anatomy and physiology. Now, I realize that's a pretty broad topic. We're actually going to do, over the next couple months, we'll do a number of live reviews that'll cover cardio. So in this first one here, we're just going to cover, a reasonable amount of concepts because we know you have other things to do. So we'll keep this a nice length session for you, where we'll cover a little bit of anatomy, a little bit of physiology. These concepts are kind of corresponding to what we've been covering in the DaVinci Cases, which is our weekly video series. You may notice every Wednesday we put out a new clinical case video on YouTube and on our website and on Instagram's IGTV. So as we're waiting here just for a few more people to join in for us, this is put out by DaVinci Academy. I'm the lead educator here at DaVinci Academy. Our website, www.dviacademy.com. What we are a company that puts out outline format textbooks and online video courses. We have first for anatomy, so we have a 310-page book with over 200 diagrams and radiology images. It's meant to supplement any medical school or graduate school course in anatomy, and then also serve as a great review for if you're about to graduate medical school and start surgical training or some other internal medicine or some kind of residency training. We have biochemistry, which is a great supplement as well for any biochemistry course, whether you're in undergrad, graduate school, medical school, dental school. Again, it's a little bit shorter, 139 pages, outline format, over 80 diagrams. Both these books are great uses for reviewing the USMLE as well. And then obviously, like I was mentioning, DaVinci Cases, our free weekly clinical case video series on YouTube. We've got links in the description below of the YouTube video if you want to check those out. So, and then these are our monthly subscription packages for the video, and you can find these again on our website. So we try to keep it a reasonable price. You can try it out for free for 7 days, and if you don't like it, then you can just cancel it. No hard feelings, no charges. And then also you can also, if you do like it, hopefully you do, you can use it for as long as you want. 1 month, 6 months, a whole year, 2 years, however long you want to use it. It's sort of like Netflix, and then you can cancel it anytime you want. We made it easy for you to cancel as well. So now that we've got that out of the way, let's talk about this plan for the session. We're going to be talking about coronary anatomy, valve pathology, pressure volume loops, and then the cardiac cycle. A lot of this is going to be case-based. We felt like the feedback I've gotten from people who have attended these before, and then just other live sessions I've done as a tutor in medical school, that people like to have the cases because it just kind of brings the material to life and it makes it more memorable. And then also feel free to ask any questions throughout the session. And you can just put those in the comments there on the side. You can just type your comments in. I can see your comments as they come in. If you have a comment or if you want to just say something, that's fine too. Just meant to be as interactive as possible. Really appreciate you guys joining in here. So let's just review our coronary anatomy first. So to answer our first case, you're going to have to just remember this, and let's just go over this real briefly here. So if you remember, the coronary arteries come off of the aortic root, which is just right here as it comes off the left ventricle. And remember, you have two main ones. You have the RCA, the right coronary artery, and then you have the LCA, or the left coronary artery, which is labeled here. So let's start with the left here. So the left, it bifurcates right away, and your anatomical landmark is this left atrial appendage, which you can see here. And so then it splits into the LAD, which you can see here. And the LAD travels down sort of the center of the heart. It sort of divides the left ventricle and the right ventricle. And so it's the main supply to left ventricle. You may have heard of this called the widowmaker. And because if you have an infarction in this artery, it can be very devastating, often fatal, because it's such a main supply to the left ventricle. It supplies the anterior 2/3 of the interventricular septum, so very critical. The other artery that branches off the left coronary is the left circumflex artery, and you can see that here. And then what this does is it travels around, it helps the LAD supply the left ventricle. But then as you can see, it's kind of faded here in the diagram. It kind of wraps around the back here, around the posterior aspect of the heart, and supplies the posterior aspect as well. And so that's an important one to remember there. And then on the right side here, you have the right coronary. It's a little more simple. So the right coronary comes off, it travels under the right atrial appendage, and it keeps traveling, and then it travels and it supplies most of the right ventricle. As you can see, you have this right marginal artery that supplies, that helps come down the right ventricle here and supply some of the right ventricle. And then as you can see, the RCA wraps around here, and then you have the posterior descending, which in most people, remember coronary dominance, we'll talk about that in a second here, but in most people it comes off, the posterior descending artery will come off of the right coronary, and it can also come off the left circumflex in some individuals, and where it will come down, and then it comes down the posterior, or more so the diaphragmatic surface. So it comes down like it's either the diaphragmatic or it's also called the inferior surface, because if you remember the way the heart rests in the chest, it rests right on top of the diaphragm. It's kind of the way the surface is the way it's oriented is that this surface here is more so the diaphragmatic surface because it rests right on the diaphragm, or inferior surface it can be also called. So if you hear someone say, oh, there was an infarction, or there was the artery, often the PDA is one that they're talking about. So you have the posterior descending artery, it comes down like this, and it supplies it sort of acts in parallel as the LAD. It supplies the posterior aspect, or the posterior 1/3 of the interventricular septum, and it also helps supply the right ventricle as well. So that's the main coronary arteries. We won't go, those are really the ones you really got to be aware of, and especially for the USMLE exam if you're studying for that. All right, here, so let's hit a case here. And so if we got this case, we'll just walk through the important steps. If you want to shout out questions, and when we get to kind of hold off and be guessing until we get to the end of the stem here, in case some people are just kind of following along. So first we have a 67-year-old man, so elderly man. If you remember, for men, it's about 55 and older. For males, they're at risk for coronary artery disease, and then in females, it's 65. And that's mainly thought to that females have, it's not fully understood, but one thing that's thought is that females have higher levels of HDL, which helps kind of scavenge and clear the heart of bad cholesterol. So that's one thing. And then it's also thought to be due partly to the increased levels of estrogen having some kind of cardiac protective mechanism as well. But generally, just you want to remember these as kind of the risk factors. So as a male, he's well above that. So anyways, he presents to the emergency department. He's got substernal chest pain. So he's got that classic, burdening chest pain. His symptoms also include dyspnea, shortness of breath, diaphoresis, so he's sweating. And these are very common symptoms to have with a myocardial infarction. EKG is done in the ED. It indicates an ST segment elevation in the leads 2, 3, and AVF. So if you're not too familiar, if you're more in the preclinical years and you're not as familiar with EKGs yet, that's okay. You're going to see these on your step 1. You obviously will see them on step 2, and at that point you should be a little more familiar with them. At this point, the big thing you want to take away from this sentence is there's ST segment elevation, which corresponds to what's called a STEMI. So there's STEMI and then non-STEMI. So STEMI refers to, if you recall, the histology of the heart. So this is the lumen of the ventricle. And then if you remember, you have your layers here. So this is the endocardium. This is the myocardium. This is the epicardium. And so this is the lumen. This is where the blood is within the ventricle, and so you have the endocardium. And this diagram is misleading. The majority of this mass is the myocardium. And so what a STEMI stands for is transmural necrosis, which means that all 3 layers are having necrosis occur. And so this is pretty significant. It's the entire wall of the ventricle. So this is what's called transmural necrosis. And so you want to remember that. So STEMI is very significant. It's very serious. It's a much more, not that a non-STEMI is not serious. A non-STEMI corresponds to just subendocardial necrosis usually. So it's just in this endocardial portion here. So it's a much less, as you can see here, just by this general diagram here, it's a much less significant area of necrosis versus transmural, but still very significant. And so the thing with a STEMI, what you need to know is, as far as the next step in management, is obviously you would stabilize them and everything, but they got to go to the cath lab right away. They got to see the interventional cardiologist right away. So they go to the cath lab. That's what they did here in this case. Patient underwent angioplasty, stenting for a single vessel infarction on the diaphragmatic surface or the inferior surface of the heart. And then the patient is also found to have left dominant coronary circulation. The procedure is successful and the patient's sent to the coronary care unit. So that's pretty standard. So the big takeaway here is they have this single vessel disease. It's on the diaphragmatic surface, and then it's the left dominant coronary circulation. So if you recall, the main artery on the diaphragmatic surface that we talked about is that posterior descending artery. So the question here is, which coronary artery is the origin of the artery affected in this patient? And so what this question's asking is, what is the origin of the posterior descending artery in a patient with left dominant coronary circulation? So before we answer that question, let's go back and cover the right dominant versus left dominant. So as far as right dominant, so right dominant is where this is the majority of patients, and so, or the majority of people, I should say, not just people who go to the doctor. So this is the majority, right dominant. So right dominant is going to correspond to the right coronary artery, giving rise to the posterior descending artery. So if someone's right dominant, the right coronary artery is going to come off here. It's going to wrap around the posterior aspect of the right ventricle, and it's going to give off the posterior descending artery here. However, if someone is left dominant, which is a much smaller percentage of the population, what's going to happen with them is you're going to have, you have your left coronary artery here, right? And it comes down and it splits into your LAD and your left circumflex. Left circumflex wraps around the left ventricle, and then the left circumflex is going to give rise to the PDA. And so that will be in patients that are left dominant, the left circumflex will be the source of the posterior descending artery. Now, there's also a third, which is much smaller, about 1% of the population or so, which are called codominant. So you may see this as well. Codominant is where the PDA originates from both. So you have the RCA here, and then you have the left circumflex here, LCX, and then they both sort of merge together to give rise to the posterior descending, and that's codominant. So it's sourced from both of them. So this is really important to remember. The USMLE likes to ask this a lot. You can definitely see this on an anatomy or a physiology exam as well. So if we come back to the question here, which coronary artery is the origin of the artery affected in this patient? And again, you always want to come back to, what really is the question asking. So it's really asking, what is the origin of the posterior descending artery in a left dominant patient? So let's go through the answer choices. Remember, the LAD comes off the left coronary. So you have the left coronary like this, under the left atrial appendage, gives rise to the LAD, which goes down the center of the heart, sort of. And then you have the left circumflex like that. So it can't be that. Then you have the left circumflex, which is in fact our answer, as you probably have deduced by now. So that's our answer. Left circumflex will wrap around the heart and give rise to the PDA in a left dominant patient. Right coronary would be if the patient was right dominant. This would have been the right answer. But since this patient is left dominant, this is not. And then the right marginal will never give rise to the posterior descending artery. The right marginal always comes off the right coronary. And again, it's kind of a helper. It helps supply the right ventricle. So this is a question, it helps test your knowledge of myocardial infarction, your presentation. It has a little bit of an EKG component into it. And then what this question really at the end of the day is testing is, do you understand, the coronary anatomy, and then do you understand, right dominant versus left dominant versus codominant? So that's that question right there. So as far as next, we'll cover pressure volume loops. So pressure volume loops, they can be somewhat challenging when you're first learning them, but they're really not that bad as if you just kind of break them down into phases or into components. And so what we'll do here is we'll go through, the different components, and then after this we'll have a question that will allow us to, explore different variants. Because usually what the questions will ask, what this USMLE questions will ask is, it'll have some variant of. They'll have some variant of a pressure volume loop, and so you've got to be able to identify. And we have a nice practice question for that. This past week's DaVinci cases also has that as well. So if you saw that, you're probably gonna have a leg up on this. So on the vertical axis you have left ventricular pressure. On the horizontal axis you have left ventricular volume. So what you want to do is I like to start over here at this point, because as you can see, as you go from here to here, you're dramatically increasing the volume, but you're not really increasing the pressure as much. And so what 4:1 corresponds to is diastolic filling. And so what's happening here is that the pressure in the left atrium is greater than the pressure in the left ventricle. And so that's what's driving. Remember, fluid moves from high pressure to low pressure. And so in this case, it's going to move from the high pressure of the left atrium to the high pressure of the left ventricle. And so that's going to drive filling. And that's what's going to drive filling into the left ventricle. And so at this point, the mitral valve is open. And that's also what drives opening of the mitral valve, is that when this pressure in the left atrium is higher than the pressure in the left ventricle. So at this point, point 4 is where the mitral valve would be open. Next, we have isovolumetric contraction, which is the point from 1 to 2 here. So 1 to 2 is isovolumetric contraction. So isovolumetric contraction, it's in the name, isovolumetric, so it means that the volume is staying the same, and you can see that the line goes straight up like this. What you should notice is that the pressure dramatically increases. And so during this point, from 1 to 2, all valves are closed. So the mitral valve is closed and the aortic valve is closed, because what you're doing here is, if we draw the heart up here, if you have your left ventricle like this, you're having that concentric, contraction like this during this point, where you're trying to essentially decrease the volume of, not the blood volume, but the volume of the chamber itself. You're trying to compress, and because if you remember from physics that pressure and volume are inversely related. So if you decrease the volume, you're going to increase the pressure, and so that's what you're essentially doing here. And so at that point, what you're doing when you get to point 2 here, this is what's corresponding to the aortic valve opening, because at this point, what has occurred is that the pressure in the left ventricle is greater than the pressure in the aorta. And so then the aortic valve opens. And so at that point, what then you're going to have is from 2 to 3 here, is you're going to have systolic ejection. So from 2 to 3 is systolic ejection. Now, what I should point out, and I forgot to point out here, is at point 1, what this corresponds to is what's called the end diastolic volume. So remember, 4:1 is diastolic filling. So at this point, you've maximally filled the left ventricle. This is called, and it's the end of diastole. You're getting ready for the pumping action of systole. So this is where you have what's called the end diastolic volume. This is really important. At this point, you're at the end of systolic ejection at point 3 here. So at point 3, what this corresponds to is the end systolic volume. So this is the volume of blood that's left over in the ventricle after systolic ejection. It's really important to remember the ventricle doesn't completely empty itself. So let's say, just for figure's sake, let's say you have 140 milliliters as your end diastolic volume, okay? Then let's say you go through pumping and you pump out, and at the end you have an end systolic volume of 70 milliliters. So that would be your end systolic volume. The difference between that will then give you that there were 70 milliliters pumped out. So 70 of this 140 were actually pumped out, and you were left with 70. So what that gives you actually is if you take the end diastolic volume, which is the volume you start with at the beginning of systole after diastolic filling, and you subtract end systolic volume, which is the volume left over after systole, what you'll get is what's called the stroke volume, or SV. The stroke volume is the amount of blood that was ejected during systole. Now, on a pressure volume loop, that's actually the distance between, or it's essentially the width of the loop, like this. So from here to here, because you can see the volume doesn't change on these vertical lines here. So that's really important. It's really important to remember if the end systolic volume changes, if the end diastolic volume changes, if the stroke volume changes, because that can help you figure out the different, pathophysiology occurring. So then if we come here, so then we have isovolumetric relaxation, which is 3 to 4. So we'll draw that down here. So 3 to 4 is isovolumetric relaxation. And so this is when it's in the name. The muscle's relaxing. You're allowing the pressure to fall. And so what you're really doing is you're allowing the pressure to fall back to 0.4 here, which is, remember, when the mitral valve is going to open, when the pressure in the left atrium is above the pressure in the left ventricle. So here you're waiting for the muscle to relax to the point where the pressure in the left ventricle is less than the pressure in the left atrium, and then you can open the mitral valve and begin diastolic filling again. And so then the pressure volume loop begins all over again. So again, I know that I kind of went through it. I think you just need to go through these systematically. You need to start at a certain point. I like to start over here at diastolic filling, and you just need to remember what each of these points on the graph represent. So let's go to a case here. So the case here. So if we have the case here, it's a 44-year-old male. So it's a younger guy here, and he was presenting to his physician's office with fatigue, shortness of breath, and difficulty swallowing. It's interesting. 44 is pretty young. I mean, that's below that 55 cutoff for males, so you may be less suspicious of coronary. It's certainly someone in their 40s can have coronary artery disease, but it's not as common. But you always want to keep that in mind. Shortness of breath, these are also symptoms. It could be a pulmonary issue as well. He could have COPD, or he could have some other type of, he could also just have like an infection in his lungs as well. So these are sort of non-specific. So let's keep reading here to see what else we find. So the patient's also experiencing episodes at night that involve waking up with significant shortness of breath and coughing. This is really important. This is called paroxysmal nocturnal in the dyspnea. And so, sorry, my thing is acting goofy. And so this is where he's waking up at night with severe shortness of breath. Now, what's important to remember is that at night you're lying down, and so there's less blood. Remember, when you're standing up, the blood will pool because of gravity in your legs. That doesn't occur during when you're lying down. So that's important to remember. I'll come back and explain this more in detail in a second here. Let's just get through the rest of the stem here. So the patient is an immigrant from Africa, so that can be important to remember, because some patients that are from certain regions of the world are at risk for certain diseases, certain infections, so that can be important to remember. He has no significant past medical history beyond upper respiratory infections as a child. So he's from Africa. He had some respiratory infections as a child, but otherwise he's an otherwise healthy guy. He doesn't take any medications, as it says here in the next sentence. Physical exam is notable for a rumbling diastolic murmur with an opening snap, best heard at the apex. And so best heard at the, so this is best heard at the apex. So let's think about what this means. So best heard at the apex would mean, if you remember the heart like this. So here's your mitral valve like this. Here's your left atrium. And then here's your aortic valve here with your aorta, and this is your left ventricle. So here's the apex of the heart, which is at the point here. And so what you'll have here is, if you're listening here, you're best going to hear the mitral valve, which is shown here. And so, you're going to hear rumbling, as we say here, rumbling diastolic murmur. So if you remember during diastole, as we talked about during the pressure valve movement, the mitral valve is supposed to be open. So if you're hearing a mitral valve murmur during diastole, what that means is that there's the mitral valve essentially is having trouble opening. And so you're hearing, if the mitral valve opens normally, you should be very quiet. You shouldn't really hear. You should just hear that lub dub when the valves are closing. But when the mitral valve is opening, you shouldn't really be hearing anything. You're also hearing this opening snap. And so what that corresponds to is that the mitral valve is having trouble opening. And if you remember, the mitral valve has two leaflets. And so it's essentially like this, where it's not, if this was normal, the leaflets would be much more open. You'd have much more space here for blood. Here, they're barely opening up. And so what's happening is you're having significant difficulty getting blood out of the mitral valve. And this is essentially what's called mitral stenosis. And so mitral stenosis, obviously, it impedes the ability to pump blood out of the left atrium into the left ventricle. And so you can have blood building up back into the left atrium. So the rest here, physical exam, basilar crackles of both lungs, and then bilateral pedal edema. So what do we have here? We've got a guy who's an immigrant from Africa. He had some respiratory infections as a child. Otherwise, nothing really notable. He's got this diastolic murmur with a snap as heard at the apex. He's got crackles of both lungs, bilateral pedal edema, and then he's got shortness of breath and difficulty swallowing. So what's important to remember for mitral stenosis, and let's actually go to the next slide here. So as far as the dysphagia goes, if you recall here, this isn't the best diagram to illustrate this, but it gives you a sense. So this is a cross section. This is an axial view. You can see the heart here. And so if we show this, if we were to go a little further down here, if you have the left atrium like this, you actually have the esophagus. The esophagus actually travels anatomically just posterior to the left atrium. So if this is the vertebral body like this, and then if you had the ribs coming off like that. So if this is anterior, this is posterior. The left atrium is just anterior to the esophagus. So if you're having trouble getting blood out and the left atrium expands, as you can see here, it's going to impinge on the esophagus. So that's how you get dysphagia or difficulty swallowing. It's not very common in real life, but it's something that, and mitral stenosis is actually one of the rare valve conditions. But the USMLE especially loves to test about this. They love to test about mitral stenosis. They also love to test about dysphagia from that. So that's a very common anatomy question. That's why we're covering this, so you'll be ready for that. So that's important. The other thing is that the left atrium, you have the veins that are coming in from the lungs. So you have these pulmonary veins that are coming. Remember, the left atrium is where the pulmonary circulation drains into. And so if you have, essentially here, we'll have like just a box like this. It's a very crude diagram, but you'll get the point. The left atrium like this, you have the pulmonary veins draining in. And then here you have the pulmonary circulation will be this kind of donut-shaped or round-shaped structure like this. So if you have stenosis into the left ventricle like this, so if you're having buildup of fluid back like this and you're building up pressure and you're having trouble emptying the left atrium, what that's going to do is then it's going to cause increased pressure in the pulmonary veins, which is then going to back up and cause increased pressure here in the pulmonary circulation. And as a result of increased pressure in the circulation, that's going to cause fluid to leak out. So it's going to cause fluid to leak out, which is also known as edema. Oh, what's this thing doing? All right, sorry about that. Which is clinically called edema. So it's going to cause pulmonary edema, and it's going to have symptoms sort of that are mimicking to heart failure, left ventricular heart failure. You can certainly develop heart failure eventually from mitral stenosis. But the thing to remember is that it's more so the mitral stenosis causing backup of pressure back into the pulmonary circulation, and you have edema. That's where you get the crackles or rails on physical exam. So crackles on physical exam. So that, because remember, crackles just essentially means water, fluid in the lungs. Could be a cause of a lot of things. But when you pair everything together, that's how you get the crackles on physical exam, is from the buildup back into the pulmonary circulation. So that's important to remember. That can happen in mitral stenosis. It can happen in it can happen in heart failure as well. Very common. So if we come back to the stem here, so we've explained, and then bilateral pedal edema is a result of continuing to back up into the lungs. What you have there is that's just buildup of edema within the lower extremities. And so what eventually happens is these patients do develop, compromised heart function, and so you have buildup of fluid back into the venous system, which includes the lower extremities, which the lower extremities are especially more prone to edema because of the gravity component as well. So as far as this, the other thing here is waking up with significant shortness of breath and coughing during the night. When you lie back, we'll come back to this to show this for a second. When you're lying down, that's going to decrease the blood flow to the legs, or decrease the venous, not decrease the blood flow to the legs, decrease the venous buildup of the pooling of blood in the veins of the legs. And what it actually does is, by lying back, you actually further exacerbate this backup of fluid back into the pulmonary circulation. And so when someone's lying down and sleeping all night, it's going to further exacerbate this, and it's going to get to the point where they're going to have this fluid that'll be leaking out and interfering with gas exchange, and then they'll wake up with serious shortness of breath. And then that's where they have these episodes. These are common for chronic mitral stenosis, and also common for heart failure as well. Now, mitral stenosis, the most common cause is what's called rheumatic fever, now, this is more common in certain parts of the world than others. In the U.S., it's not very common at all. And so on the USMLE, it's more concerned with, or not concerned with, but it's more so describing the U.S. population, usually with the questions in the USMLE. So if they talk about an immigrant, they're talking about an immigrant to the U.S. from wherever they mention. So in this case, it's Africa. Africa patients are unfortunately more at risk for developing rheumatic fever. This is supposed to tip you off to that, the upper respiratory infections as a child, because usually they would get these infections as a child, and then it would be chronic damage that occurs, over time. It's not like usually they don't have it just right after. It's usually a more chronic or long-term side effect of having rheumatic fever. So we've established that it's mitral stenosis. Now at this point, what do we need to do? We still need to answer the question. This is a great question. This is a great USMLE style question because it tests both. It's essentially a two-step question. You need to figure out that this is mitral stenosis. And then here, what this is asking is, which of the following pressure volume loops reflects this patient's physiology? So what you really should be saying is, which of the following pressure volume loops reflects mitral stenosis? That's essentially what they're asking. So now that we know what we're looking for, it'll make it much easier when we go through these. Now, so for the purpose of learning and the purpose of this review, we'll go through each of these and explain them. So the first pressure volume loop here. So let's start over here. This is where the mitral valve would have opened. But as you can see, they'll show you these on exams a lot. So the solid line is the normal, the dotted line is the abnormal. And so what you've seen is you kind of shifted the starting point here. And so you've moved from this point to this point. And so what's happened here is that at this point, this is where you're going to start with filling. So you're going to go towards here. And then at this point, this is going to be the end diastolic volume, if you recall. So the end diastolic volume is going to be here. This is the end of filling. And as you can see, the end diastolic volume is unchanged or the same. And so that's significant. We'll keep that in mind. So that's unchanged. What that also means is that the preload is the same. And so with the preload essentially is the stretching of the ventricular muscle. You could think of it as it's similar to stretching your skeletal muscle. So you stretch it out. You're going to stretch it out maximally by filling to the maximum point here. And so you can, and then you can also, you can increase your preload, so you can further stretch the ventricle. You can also decrease your preload, which would not stretch your ventricular muscle out as much, and it wouldn't be as powerful. So that's the significance of preload. So then here, as you can see, isovolumetric contraction is pretty much the same. And as you can see here, it opens up where the aortic valve opens. It's not as dramatic of an increase as you. It's somewhat increased, but it's not anything to be where you would think that there's some kind of aortic pathology here. So if you see here, you've increased here, the aortic valve opens. Now what's dramatic here is you can see that there's dramatic increase here in the pressure. So there's dramatic increase in left ventricular pressure as during systolic or ventricular ejection. So then you get down here where the end systolic volume is decreased, as you can notice here, because if you come down here and look, it's at a much lower point than here. So the end diastolic volume is the same, and then you have a decrease in the end systolic volume. So what's important about that is, if you remember, when you subtract end diastolic volume from end systolic volume, that gives you the stroke volume. So if this is the same and this is decreased, what do you think is going to happen? What's going to happen, and you can even see this visually here, is if remember the width of the pressure volume loop is the stroke volume. So what you're going to have is increased stroke volume. Now, as far as mitral stenosis goes, mitral stenosis, you're going to have, if you think about it, you're having trouble filling the left ventricle. So you're probably not going to have the same end diastolic volume. You're going to have a decreased end diastolic volume in mitral valve stenosis. We'll do a little note over here. So that's going to have decreased end diastolic volume, because one thing, you're just not going to fill it as much. The other thing is that because you don't fill as much, because you start at a lower point, your end systolic volume will also be somewhat decreased as well. Not to the degree of your end diastolic volume, but it's going to be decreased as well. And so given that the end diastolic volume is the same, that's the really important thing, because that's really what's affected by. All right, sorry about that, guys. My connection got really broken up there. Really apologize about that. So at this point, so we were talking about this pressure volume loop. And again, just because we lost I really apologize about that. I'm on a different network today for some reason, not my usual network, which usually this is always run fine before. Really apologize about that. Anyways, so again, remember what the key findings here again is end diastolic volume is the same, and then end systolic volume is decreased. And so if we show that here, and if you remember, during mitral valve, our patient has mitral valve stenosis, if you recall. So mitral valve stenosis, what you see with that is decreased end diastolic volume because you have trouble filling. So given that the end diastolic volume is the same here, and that really what you're seeing here is an increase in ejection fraction, or an increase in ejection pressure, the pressure during systolic ejection, what this really is corresponding to is increased contractility. Now, there's certain drugs that can cause increased contractility, because when you increase contractility, you increase the tension, and then the tension and the pressure within the left ventricle, as you can see here. So if you see the pressure here, the pressure is dramatically increased from here to here all throughout. And the result of that, you're generating more pressure, you eject more volume. And so as you can see, your stroke volume is increased. So I would say this is not our answer choice, because it's increased contractility. So back to this number B, or answer choice B here, left vent. What we can see here is, all right, so we've shifted this already over here. So you can see we're starting at a higher, what's interesting here is we have a higher end systolic volume. That's not necessarily a good thing, because what that means is we didn't eject as much blood as usual out of blood. There's more blood left over. So we're already starting out with a higher amount of blood when we begin with diastolic filling. So if we come over here, what you can see here is that end diastolic volume is somewhat increased. So if we come over here and we go through this point here, what's really noticeable is, as you can see at this point here, during isovolumetric contraction, this is when the aortic valve would be open. So if you'll notice, you had to generate, if you look at the pressure between here is normal, if the pressure here, pressure 1 and pressure 2 here, pressure 2 at this point is much higher. So you had to generate a lot more pressure just to open the aortic valve. And remember, at this point where the aortic valve is opening, that's where the pressure in the left ventricle, as we said before, is greater than the pressure in the aorta. So at this point, as you can see, it's much more increased pressure. But and then at this point, but you may be thinking, well, this is sort of similar to before. Did they just increase contractility? That's not true. So what this is for is aortic stenosis. This is a classic PV loop for aortic stenosis, because the aortic valve is stenotic. So if you remember, the aortic valve looks like a Mercedes car emblem, like that when it's closed, and then when it's opened, it should be, the leaflet should be tucked back like this, and you should have a nice open flow. In aortic stenosis, though, what happens is the leaflets don't really fully open. It's like sticking your thumb on the end of a garden hose, and so you have really dramatically, this is much less, orifice. This is a much smaller orifice than this. So you're going to have dramatically increased resistance. And so as a result of having dramatically increased resistance, you have to spend so much more of your isovolumetric contraction on generating more pressure to overcome this resistance, just to even get the aortic valve open, just to get it open even. We're not even talking about increasing, to compensate for, or to increase, increase ejection volume. And so at this point, you've just gotten to the baseline of where you've opened the aortic valve. And so at this point, as a result of that, as a result of blowing that energy, or having to use up that energy on just contracting and get to the point of opening the valve, what you have is a much decreased stroke volume. And so you have an increased end systolic volume because you just didn't get as much blood out. And then sure, this end diastolic volume is increased, but you got to recall the reason the end diastolic volume is, and it's not increased very much. If you can see, it's a much smaller than this point here, is because you started at a higher point. It's like if you have a glass of water and you only come down to here and then you refill it back, back up, and then you refill it, you've already started, versus if you had the same amount in here and then you practically almost emptied it down here. So if you have this much water left over, but then you refill it, you're going to refill it to a higher point if you put the same amount of water in. If you put the same amount of water in both of these, if you started at this point here versus this point here, and you put the same amount of water in, you're going to fill it up it's going to fill up to a higher point on the glass. It's the same kind of thing. So you're starting with a higher volume to begin with. So at the end, and by default, you're just going to have a higher end diastolic volume. So you can't think too much into that. What's really important is that the stroke volume is decreased, and this is characteristic shape because the pressure had to be so much higher to overcome that resistance. So this isn't our answer choice either. So let's come to answer choice C here. So if we notice here, if we come from, if we go across filling, it's shifted, the end diastolic volume is dramatically decreased here. So as a result of that, you're going to have decreased preload. You didn't stretch out the ventricular muscles as much. So you have decreased end diastolic volume. And so as a result of decreased end diastolic volume, what's going to happen as a result of that is that you're already starting at, a lower preload. And so as a result of that, there's not as much blood to pump out. What we should notice here is that contractility is the same. And then afterload is the same. Because if you see here, the reason why you see this significant decrease is because of the decreased preload. So you have significantly decreased pressure during systolic ejection, at this point on the curve. So you've dramatically decreased that. So when you get to this point, if you'll notice, the end the end systolic volume is decreased as well. And so it's not as significant though as the end diastolic volume decrease, because the end diastolic volume is really what's caused this lower, and it's a cause and effect type thing. You've decreased the end diastolic volume, and as a result of that, you've decreased the end systolic volume as well, or you've shifted it versus normal. This is comparing it to normal. So what's important about this is really what's the key here is that you had this decreased end diastolic volume, which resulted in this decreased preload here, which then kind of set off this chain reaction. You didn't eject as much blood, and so as a result of that, your stroke volume was decreased as well. So you have decreased because you just didn't start with as much. So I think this sounds very similar to what we've been talking about. And so if you remember with the left atrium, and then if we have the left ventricle like this, and then here's the mitral valve, there's the aorta here. If you have a stenotic valve and it's just not getting as much blood into here, you're not going to fill it as much. And so versus if you were in normal up here, so you don't fill it as much. And this is a dramatic exaggeration, but you get the picture here. If you're not filling it up as much, there's not as much blood to eject. You also don't stretch out the ventricle as much. You don't essentially give it as much preload. So it's not going to be as strong, so you're not going to inject as much. So I would say this looks like a very likely answer choice. So this looks like our answer choice for mitral valve, mitral stenosis. Let's just cover the last answer choice here. So if you look here, the major difference here is right here. So you have increased end diastolic volume, which corresponds to an increase preload. And I think that's really going to be it for this one, because you increase the preload. As you can see here, as a result of that, you didn't really increase the contractility, because this part of the curve is pretty much, the reason that you see this is just because you've increased the preload. As you can see, as it gets to this point, it kind of normals out. End systolic volume is the same, and then relaxation is the same, and then really what you just see is a higher end diastolic volume. And so this is as a result of increased preload. As you stretch it out more, you're going to have increased stroke volume. And so as a result of increased end diastolic volume, increased stroke volume, this is going to be an increase of preload. That's really all this corresponds to. So this can't be it either, because in mitral stenosis, you're decreasing the preload. So this is really the direct opposite of our patient. And an example of this could be clinically if you gave like IV fluids. Like that's one of the benefits of giving IV fluids is that it increases the preload, so it can help with heart function. So again, I don't think this is our answer choice here. So if we come back to the question here, the patient has mitral stenosis, and they're asking for which one. So if you remember, just to review these briefly, this is increased contractility. This was aortic stenosis. This was mitral stenosis. And this was increased preload. So this was our answer choice here, choice C. Last case here, and then I'll let you guys go. Thanks for sticking it out here with me. So this is a 76-year-old man. He presents to the physician's office after experiencing 3 fainting episodes over the past month. 2 of the episodes occurred while gardening, and the 3rd occurred while playing with his grandson in the backyard. So we've got an elderly gentleman. He's been passing out, always concerning. Notice, though, this is what's called exertional syncope. He's not passing out while he's sitting in a chair, or at the dinner table or something like that. He's passing out while he's passing out while exerting himself, while his heart rate's increased, he's exercising. Patient has been experiencing chest pain after long walks and climbing stairs. So this is what's called exertional angina. So again, it's not unstable angina, which is where you're sitting down or resting. This is also known as stable angina. Sorry, this just looks terrible. We'll rewrite it here. Exertional angina. So past medical history is notable for hyperlipidemia, certainly a cardiovascular risk factor, but he takes atorvastatin, which would be to help with that. He takes a daily multivitamin. Physical exam, it reveals an S4 heart sound. This is ventricular stiffening is usually what this corresponds to, especially in an older individual. Ventricular stiffening is going to be against increased resistance. Could be chronic hypertension, especially if it's untreated or uncontrolled. Could also be aortic stenosis. So let's see if he has a murmur here. So he does, whole systolic murmur over the right second intercostal space that radiates to the carotid arteries. So if you remember, if you're at the right second intercostal space, this is the aortic valve. That's where you're oscillating. So if you hear a murmur during systole for the aorta, it means just like when we were talking about with the mitral valve during diastole, when the mitral valve is supposed to be open. During systole, the aortic valve is supposed to be open. And so as a result of that, it's because the aortic valve has trouble opening. And so if we show this here, the aortic valve is having trouble opening. And remember what we said about that when we talked about the PV loop for it, is increased resistance, which is also known as increased afterload, which is essentially the force that the ventricle has to pump against. So remember, like it showed nicely in the PV loop, is the ventricle has to work so much harder just to even overcome that resistance, just to get blood out of the ventricle. And this is classic for an aortic stenotic murmur, is that it's going to radiate to the carotid arteries. So we've got a patient here, and then clinic, as far as the symptoms go, exertional syncope, very classic for aortic stenosis in an elderly person. This is very common in elderly people because just over time, just like how arteries get stiffened, the coronary arteries, the aortic valve gets stiffened as well. It's just another bad thing, unfortunate thing that happens with old age. Exert yourself, you're not getting as much blood out of the aortic valve. You need higher, ejection, you need more blood ejected out during exercise. It's just as simple as you're not getting as much blood out, decreased blood flow to the brain. And so when the brain doesn't get adequate blood flow, person passes out. Also, patients with aortic stenosis, they can have exertional chest pain or exertional angina. So he could have some underlying coronary artery disease. It could just be due to his aortic valve. Hyperlipidemia is also a risk factor for certainly coronary artery disease, but also for aortic stenosis. So keep that in mind. So what this question is really getting at is that it's a two-part thing, just like the last one. You want to identify that it's aortic stenosis, and then we look at the question here, which of the following points corresponds to the murmur in this patient? So it's really what's corresponding. When you hear the murmur, when the aortic valve has trouble opening. And so what this question is asking is, which of the following points corresponds to AV opening? So let's walk through this. So we've got pressure on the vertical axis. This is also, just like the PV loops, this is very common for the USMLE, that they're going to ask that you have to find the diagnosis, and then you've got like a graph, physiological graph here where you got to figure it out. So if we look here in this kind of goldish yellow color, this is atrial pressure. The green here is ventricular. We'll just say this is left ventricular pressure, left atrial pressure, because we're focusing on the ventricle. And so if you look here, let's just start here. If you look at the green line, this is LV pressure. It's lower than the atrial pressure. So at this point, the pressure in the left atrium is higher than the pressure in the left ventricle. So from this point, this is going to be diastole or diastolic filling. Because remember, that's when, just like on the PV loop, that's when you're having filling of the ventricle, because the pressure is driving blood flow from the atria to the ventricles. So at this point here, then you have where it kind of converges here and meets. This is where the atrioventricular valves, or in this case, the mitral valve, would close. So that's where the mitral valve closes. Okay, so then we go from there, from where the mitral valve closes, then you have, let's follow the green line, then you have a dramatic increase here in ventricular pressure. So notice you started all the way down here and you're coming up here. So this is the pressure in the aorta. And so if you notice here at point A, at point 8 here, this is where, if you look here, at this point, this is where the pressure in the left ventricle is getting greater than the pressure in the aorta. So what valve opens with that? The aortic valve. This is when the aortic valve opens. So it appears that's probably our answer choice, is answer choice A. Let's just go through the rest of this for completeness sake. So point C is where the mitral valve closes. Point A is where the aortic valve opens, which is our answer. And then if we come along here, we follow along, it's about the same. this is that diastolic. This is where you have that diastolic rebound in the aorta, because then here you have where the pressure in the ventricle has decreased below the pressure in the aorta. This is where the aortic valve is going to close. And remember, the aorta is very elastic, so it stretches and then it's going to recoil during diastole, and that's going to give you this kind of bump in pressure in the aorta. And that gives you kind of that diastolic pulse of blood. And so then you have this dramatic decrease as you go down here in pressure in the left ventricle, and you get to this point here. Sorry about that. You get down to this point here where the mitral valve will be able to open again. And so here the mitral valve will open again, and then this is, as you can see, this point here corresponds to here. And so again here, then you're going to have diastolic filling. And so again here, this just shows the the answers filling in from the diagram I took this from. All right, so that's about an hour. We'll cut it off there. Again, remember, we'll do, if you want more cardio, we're certainly DaVinci cases over the next, I would say we've done 3 so far. We're going to be doing about 10 per organ system. So we've got 3 DaVinci cases videos already. The link to the playlist for that is in our description. If you don't subscribe to our YouTube channel, please subscribe. I really appreciate it. We put out new videos every week, new DaVinci cases every week. We put out some other sample videos as well very often. We do one of these live reviews every month. You don't want to miss those. If you want to watch this video again, it's going to be recorded. The other thing is check out our anatomy and biochemistry books, like I talked about, our video courses on our website, dviacademy.com. And I know a lot of you guys follow us on social media. Really appreciate that. I appreciate your likes, your comments, your messages. Please continue to do that. We enjoy putting out this content for you. I'm so glad that it helped. There's so many of you that say that this is so helpful and that it helps with your studies and your exams. And so I'm really glad, really happy to hear that. That really keeps us going here at DaVinci Academy. And if you don't follow us on one of these already, please follow us on Instagram, Twitter, Facebook, and then obviously on YouTube as well. And then check out our website. All right, guys, thanks a lot. We really appreciate you tuning in for this live review, or if you're watching in the recorded version, we appreciate that again. And thanks again. We'll definitely post on Instagram and Twitter and our other social media and on our mailing list. If you're not on our mailing list, you should check that out as well. We send out blogs every week on our website. We send out updates we give out discounts as well. So that's good to check out as well. So you should go to our website and join our mailing list as well. All right, guys. Well, thanks again. We'll do another live review in June sometime. Again, it'll be cardio. So we'll cover some more cardiovascular. And in the meantime, stay tuned for the new DaVinci cases coming out every week over the next month and a half or so. It's going to be more cardio as well. So, all right, guys. Thanks.